Good afternoon, everyone. Hopefully you can all hear me. I'm Neil Bentley from ProLab Diagnostics, Scientific Officer, and we'll wait a few more minutes just to see if anybody else wants to join, and then we'll get on with it. So bear with for just more people to join. Okay, I think we've got around about 75, 80 people. So I think I should start. So I'm Neil Bentley, and I'm Scientific Officer at ProLab Diagnostics. And on reading through some information in the world's press and the World Health Organization sites and things, I came across Candida auris, which I guess you all pretty much know about, but I thought it warranted a webinar so we can just update all you busy people on what this bug is doing at the moment, or from my perspective, what I've read that this bug is doing, and some of the issues that it's causing. So I'll go into the details of what I know. If there are any questions, if you put them in the chat, and being a usual bloke, I can't multitask, so I'll have a look at the chat at the end, and we can then try and answer any of the questions. But I'll kick off now and make a go of it. So Candida auris, the title I've called is the yeast that's causing global concern, and I've seen this in from a number of angles, and it's really is starting to cause problems across the globe. So what is it? It's an emerging fungal pathogen. It was first seen in 2009. I'll come on to that in a minute. And it can cause an invasive candidiasis. Not all cases cause invasive disease, as with many candidas, but some can actually cause a very invasive candidiasis. And the problem with this is it can be really life-threatening and have a really high mortality, particularly those that are immunosuppressed. And to add to that, it's intrinsically multi-drug resistant, and it's not effective against most antifungal drugs. So we have to be really careful with this bug. Because of that, it's associated with nosocomial spread, as you might imagine, within our hospital settings. As I said, it was first identified in 2009, and this was in a 70-year-old Japanese woman isolated from an ear canal in Tokyo in a geriatric hospital. It was then first seen in South Korea in 2011, and was thought to have spread across Asia and into Europe. and was first seen in the United States in 2013. So it's now been identified across 6 continents and in more than 40 countries, although the countries where it's not been seen, when we look at the epidemiology a bit later, I'll explain why it's probably everywhere, but it's just not been identified in those places. And it was recently put on the WHO's fungal priority pathogens catalogue, which I'll go into a bit more detail a bit later on as well. Okay, so what is Candida auris? So auris is the Latin word meaning ear, hence the first case in the 70-year-old Japanese woman. It's a member of the Ascomycetes fungi of the genus Candida, which you no doubt you all know, and it grows as a yeast. It grows readily on all kinds of agar and forms a smooth, shiny, whitish grey colonies, very similar to that of Candida, other Candidas, and in particular Candida albicans. On gram, it shows as a gram-positive ellipsoid organism on microscopy. I'm sure you've all seen it. And to date, there is genetically 5 distant clades. Why they call them clades, I don't know, but they've decided to call them clades of Candida auris. Clade 1, the South Asian clade, was first detected in India and Pakistan. Clade 2, the East Asian clade, detected in Japan. Why that's not clade 1, I don't really know. That's where it was first found. Clade 3 is a South African clade. Clade 4 is the South American clade and was first seen in Venezuela. And clade 5 has recently been detected in Iran, although some of the documents out there only talk about 4 clades. They don't talk about the Iran clade as yet. Each of these clades differs in its clinical presentation, its resistance patterns, and its virulence. But for diagnostic purposes in your routine laboratories, I don't think it really matters the genetic clade as long as we can identify this by the phenotypic side of things. Okay, so why is it causing problems? Well, it's pretty difficult to identify in the routine lab because, as I've sort of alluded to, it's microscopically indistinguishable from other Candida species. And culture remains the mainstay using, and you can use chromogenic media, and it gives a blue colony with a white halo on newly found chrome agar plus, Candida plus, and it gives a pale pink colony. You can see from the picture here the different colonial types. The where I'm moving my mouse there shows the auris, and the other different Candidas show up differently. So the light blue with a halo is auris. The Tropicalis is pink with a halo, and albicans is a green-blue type of colony. So there is differential media now available. Candida auris can grow at 45 degrees, and I'll come to that. It's the importance of that a bit later. Its optimal growth is 40 degrees C, and it will quite happily grow in high salt concentrations. It is germ tube negative, and it's a budding yeast. However, on cornmeal agar, some strains can form hyphae, so it can cause problems with identification. On a lot of commercial kits and equipment, for example, the API 20C, the Vitek, the Phoenix, etc., it can be misidentified as other Candida species, and I'll come on to that a little bit later. Although the latest software versions now include a differentiation between the different Candida species. Now, in your labs, if you do identify this, I'd make sure that you've got the correct software versions that include the differentiation, because otherwise you won't pick it up. It can obviously be identified by PCR. This is usually done in the reference laboratory. And you can also screen a primary sample by PCR, and this is very useful in outbreaks investigations. However, not many of us have got a PCR for this bug, so that's an issue that we need to look at. More recently, the MouldyTOF has been used to identify it. Mouldy's never been very good at yeast and things. However, the new databases do differentiate with the different candidas. So check your database as well as your diagnostic assays to make sure you've got the most up-to-date versions. As I said, samples are sent to the reference lab for further investigation and reporting to SGSS. We do need to send samples for investigations of this bug because of its importance. However, due to the turnaround time within the reference lab, it's quite hard for them to turn these around really quickly because they may be getting lots of candidas in, particularly if you can't differentiate it from other candidas. So there's probably quite a lot of negative screening that they're doing. So it's really important that we should consider whether we can identify this, certainly to the phenotypic level locally. Just to inform you that ProLab are looking at providing a ProCult for Candida auris, and I understand that this will be available in the next 2 to 3 months. So where can it cause problems? Well, as you'd expect from a Candida, it can cause problems anywhere. So it can get in the nose, sputum, lungs, blood, liver, etc., etc. It'll quite happily live in your groin and causing no problems, but then can infect from that. So it's frequently reported in bloodstream infections, in bone, CSF, in intra-abdominal infections, wounds, ears, as the first case indicated, respiratory specimens in the urine, in bile, jejunal biopsies, and axillaries and groin, as I've said, to indicate carriage. So basically, you can get in anywhere. And what does it cause? So for a lot of people, it won't cause too many problems, but those that are perhaps immunocompromised and some other different conditions, it can cause major problems. So it usually causes problems in high-risk healthcare settings, so an HDU or an ITU department when the patients are pretty immunosuppressed and they've been been on the ward for a while, and it can infect both adults and paediatric populations. And as I said, particularly those with an underlying disease and immunosuppression. It's also causes problems with people that have been in ITU and HDUs for a long period of time, and there's further research needs to be done on this to understand the reasons behind this. But it's probably nosocomial problems here. And it's also causes problems with patients with mechanical ventilation devices, which you see in HDU and ITU, obviously. And if somebody's been on a central venous catheter line or urinary catheter or in CSF drainage devices. It also causes problems with people on broad spectrum antibiotics and antifungals, and is associated with infection in anybody that's had surgery within the last 30 days. So these are the sort of areas that you should be thinking about for your patient population groups. So how's it transmitted? Well, as I've indicated, there's a high chance of nosocomial transmission via patient to patient. The picture of the medic on at the top of the screen there is one of the things that winds me up. when they've got these stupid things around their necks, and they go around thinking that these are completely sterile, and they pass them from patient to patient. So it's just a high horse of mine there, that some of the problems associated with cross-infection is our own stupidity. So it can go from patient to patient quite easily. It's associated with nosocomial fomites from the clinical environment, and you can see the picture, the second picture there. There's all the different areas where you might be have contamination of the equipment if it's not cleaned properly, for all this multi-use equipment. Long-term colonization is reported, particularly those with on ventilator support. I've already indicated, and it's been reported that it's viable on plastic surfaces for at least 4 weeks. So it sticks around for quite a long time, and as you'd expect, it requires effective infection control. So bringing back the ward cleaners into our hospitals would be a real benefit, in my opinion. So a little bit about the mortality of this bug. As I've indicated, infections are found in patients usually that have an underlying disease, that are immunosuppressed, and kidney disease seems to be a very significant risk factor associated with mortality of patients. Early detection lowers the fertility rate, as you'd expect. Mortality is associated with invasive infection is between 40 and 60%, although you must take into account how poorly the patient is with any underlying disease when you're factoring in the cause of death. And also geographical location, the clade type, the access to the healthcare and antifungal drugs needs to be factored in. There's a lot of places in the world where there just isn't any access to antifungals. Just for information, today, there's, as far as I'm aware, there's been no fatalities in the UK outbreaks reported thus far, although there has been a number of outbreaks. So how do we treat? Well, the picture down the bottom, which we usually treat, are things of thrush and Candida infections don't work. So we need to think outside the box with this bug. The resistance is associated with a global increase of antifungals, as you would expect. Now, climate change is impacting on this bug being able to select thermotolerant environments, so it will grow, whereas other yeast won't grow. So it can proliferate due to global warming. Pan-resistant types have also been described. So it's multi-drug resistant just in its being. All antifungal breakpoints are very ill-defined. There's not been a lot of work done globally on antifungals, as you probably know. So it's difficult to know whether something is sensitive or resistant on your zone agar plate. Resistance to fluconazole is between 87 and 100%, so it's no point in using it at the moment. And there's a 30% resistance to amphotericin B. Endocannabinoids are preferred, but the availability is a problem, and even they're now beginning to show resistance. And there's development of novel fungals and drug combinations, but these are in their early stages. And examples, excuse my pronunciations here, is phosphomanogepix and ibrexafungerp are two antifungals, plus mixing amphotericin B with mycofungin as a combination therapy. They're just a couple of the examples of things that are being worked on at the moment. So a little bit more about infection prevention and control. Candida auris presents a significant burden in many countries, as I've sort of alluded to. and as it can grow at high temperatures, it is causing a global problem. And as I've said, it's quite happily grow in high salt concentrations, and can persist in the environment for long periods of time. The potential of fomites is significant, and we shouldn't underestimate what a fomite is. A lot of laboratory staff understand what fomites are, but I'm guessing that there's a lot of healthcare workers out there, they don't really understand about infection and what a fomite is. Hence the fact that many medics walk around with stethoscopes around their necks, passing infection from one to another. So we need to be really careful about all kinds of things like pens and all kinds of fomites that you can think of. Suitable cleaning and infection control measures are vital with this bug. You need to make sure you clean down properly between patients in the ward setting, and environmental and cleaning and decontamination cleaning is essential if you've had a known case on the ward. As is cleaning any equipment, it needs to be properly cleaned, not just wiped down. There's one point is, I don't know whether we should do this, and I'll be interested to see any comments in the chat, is should we consider healthcare worker screening for this bug? I'm not sure whether we need to go that far, but it's certainly something we should consider, and is probably done in outbreak situations. So a little bit about the epidemiology. As I've indicated, the global picture is difficult to ascertain due to the lack of studies, and in some areas it just won't be identified. But it has been identified across the 6 continents and in more than 40 different countries now. As I alluded to, the WHO put Candida auris on the critical priority group, indicating it a global concern for the yeast. And I've got a link to that in the talk a bit later on. Just to say what's happened in the UK between 2013 and 2021, that's the latest data I've got. There's, as far as I know, there's been 304 isolates reported, with 40 of these coming from a blood culture. Although, due to the difficulty in identification of this infection, I'm guessing that the rates are probably much, much higher than this, than the 304 that have been isolated. International patient transfers have been shown to play a part, particularly anyone coming in from the Middle East. So if you have patients coming being transferred in from the Middle East, it's well worth doing a screen for Candida auris with these patients. And in the UK, there's been 3 large nosocomial outbreaks have been recorded to date. And as I've said before, should we consider targeted screening programs now that the identification seems simpler with the AGAR and the updated software for some of the platforms. So it's just a picture from the CDC website on global spread. Now, my opinion here is that certainly in some of the Eastern European and the African countries where it's not indicated that there is any Candida auris about, it's probably because they are not screening for it, and they're certainly probably seeing candidas, but they're just calling them Candida sp. And I'm guessing that the picture is a lot worse than this graph shows. So I talked about the WHO and what they're doing. The WHO have the fungal priority pathogens list to guide research, development, and public health action. It was published in 2022, and the link is there in the presentation, which I understand we're going to send out to everybody. It's really well worth a read. In the critical group, there is Cryptococcus neoformans, Aspergillus fumigatus, Candida auris, and Candida albicans are up there. And then there's the high priority group and the medium priority group. So it's well worth a read if you're interested in fungal pathogens. So within the UK, what have we been doing about this? Well, the UK HSA have recently updated their guidelines, and we're waiting on a new document coming out from them. Interestingly, they do have a table on the UK HSA website showing some examples of misidentification of Candida auris from methods used, and you can see that it's been identified as different types of candidas or even different bugs from a number of different platforms, including Microscan, Vitek, Phoenix, etc., etc. And API 20C Orcs even is getting it wrong in certain times. So it is a problem to identify. And as I alluded to, we're waiting for the UK HSA to deliver a response to the feedback. I don't know whether any of you saw this, but the documentation went out in June 2023 until September on the data that they'd got on Candida auris, and I was hoping that the information will be out by the time of this webinar, but unfortunately it's not been released yet. So keep your eyes open on the UK HSA website to see when the latest up-to-date data comes out. With that in mind, I also had a look at the CDC US website, and they've got a fantastic website about Candida auris, and I do employ to if you're interested in this bug, really do go and have a look, because there's some really good stuff on there, and I've just gone into each of these different areas which are on the website, and there is loads and loads of information that is really interesting out there. Okay, so the first thing is about the bug. What is Candida auris? What are the symptoms? Where does it colonize? How do you diagnose it? It tells you that you don't need to treat in healthy people unless there's an outbreak situation, for obviously what are the risk factors, the resistance and treatment mechanisms, and what the outcomes are, and how to prevent spread. So it's really good information there. And how we look at the epidemiology of the bug. Now, obviously, this is initially looks at what's happening in the States, so you can see where it's causing problems. But it goes on to talk about the global situation as well later on in the document. And then there's information for healthcare professionals. It's really good stuff. So it's got a bit about surveillance, how to identify it, and of course that is changing as new AGARs are coming along, and new ways to identify identify it coming along. Yeah. What we can use for antifungal susceptibility testing and interpretation, and as I've said, we need to really work hard on getting these breakpoints sorted out, and I'm guessing BZAC and all the different areas are working hard on how to sort this out. There's a little bit about laboratory safety, how to treat and management infections and colonization, and then it goes on to infection prevention control and frequently asked questions for health professionals. It's really interesting. And then it's also got a bit for the researcher and industry, and it gives them steers and guidance on what both the research capability and industry can do to help the hospitals with this bug. So it's really, as I said, really worth a read. And then there's loads of fact sheets on there's general information about the bug, information for patients, information for the lab staff, infection control people, and also for public health professionals. So they're worth a read. And then there's a list of more resources where you can go and look for information about Candida auris if you want any more information. Now, I'm sure the UK HSA will have a similar setup to this on their website, but as I say, it's not there yet, so it's worth having a look at the CDC one. Okay, and I'm just going to move on to what the press have said about Candida auris and how they glorify things. So here's just a few headlines just to show you that I've seen. So from the Mirror, deadly fungal infection of Candida auris with death rate of 60% spreading rapidly. NBC News, deadly fungal infection spreading at an alarming rate, CDC says. And then even on the BBC News, Candida auris, the new superbug on the block. Another BBC one, Candida auris fungal infections spreading in US at an alarming rate, say CDC. Candida auris, a drug-resistant germ that spreads in healthcare facilities. And then one linked to global warming from the Sun. Heat waves fuel rise of killer fungal infection that is sweeping the globe, warn experts. So there we are. So it's just to summarize for everybody. Candida auris is an emerging pathogen. We've seen it since 2009, and it is causing problems. And we don't necessarily have the antifungals to deal with it at present. The strains can be multi-drug resistant, and they're becoming more resistant as the more drugs are used. It's a major cross-infection concern in our hospitals across the globe. And if it goes systemically in immunocompromised patients, it's got a very high mortality rate. It's difficult to identify, although the recent advances here are very helpful. Time is of the essence, so the quicker you identify this bug and treat it, the prognosis gets better. And in my opinion, this is the time for us to get smarter with this bug. We need to be thinking about how we can identify this in our local laboratories and not rely solely on the reference laboratories, who are probably overwhelmed with the amount of samples that are coming through. And it's something that we need speed on. So we need to think about doing it locally. So with that, I'd just like to say thanks for your time and for listening to me. And has anybody got any questions? I'll just now try and look in the notes pages to see if anybody's. Kerry, can you see if anybody's asked any questions? So what have I got so far? Would it be possible to gain a certificate for attending the webinar? Kerry, is that something we can do?
Yes, if you want to send me an email after, and we can get that sent out to you.
Okay, yeah, so that's
I'll put my email in the chat.
Yeah, that's a yes. Would the presentation be available for download, please? Yes, I understand it will be put on the website at some point, so you'll be able to download that. Another one, would the... Oh, it's being... Oh, somebody said it's being recorded. I told you I couldn't multitask, didn't I? I'm a bloke. So the API Candida, I alluded to the API 20C being one of the ways to identify, but it has been known to falsely identify. So if you use the Chrome Candida Plus, then that will help, but the API can give you a false result. But I don't know the stats behind that, whether it's a lot. It can be identified on the Moldy, but make sure that you've got the up-to-date software because they have updated their software to differentiate it from different candidas. Nick Parham, good to see you, Nick. Dr. Nick, we call you from The Simpsons, I think. Would it be possible to gain I can't see that. A certificate? Oh, we've already covered that. Is the presentation available? Do you think patients can be managed on local AMR patterns? It's not really my expertise here, but I certainly think that there are drug combination therapies that we need to look at. And for example, I'm not sure how liposomal amphotericin might work on patients, but certainly the newer drugs are coming out, and the drug combinations may well work. So that's something we need to look at. As I said, there's not been enough information out there, particularly about breakpoints on this drug at the moment. I work in a small lab that uses SAB routinely. Yeah, it would. Move to chromogenic Candida agar if you can, or make sure that your identification techniques can differentiate. For example, a moldy can differentiate. You've got the latest software to differentiate it from other candidas. I'm guessing there would be a potential for zoonosis from companion animals. It likes, just like any candida, it likes nice, warm, moist places. So I'm guessing that there is a chance of zoonosis, although I didn't read anything in the paperwork about that. But it might be worth having a look on the CDC site to see if there is anything about zoonoses, but I didn't notice anything. So Alicia has added, what version of moldy is needed? I don't know, I'm sorry. You'd have to check with your supplier. And Alicia has added some more information, which is really, I'm grateful of. The first case of Candida auris in Korea happened in 1996. Oh, wow. And was a case of unidentified yeast from a blood culture. It was an incidental finding when Korea conducted multicenter candidemia. Oh, right, okay. So hence the reason that clade 1 was from that area and clade 2 was from the Japan area. So thanks for that information. That's Alicia. That's really really good. Thank you for that. You raise a great point that fungal treatment should be brought in-house, as patients are very sick and need rapid specific treatment to reduce morbidity and mortality. Yeah, absolutely. Yeah, you know, when these patients go downhill, they go downhill really fast. Another one about certificate, which we've already answered. Okay, and there's been a zoonosis already reported in a dog, so that's thanks for that. What do I think about screening? Well, we've got an agar now that can differentiate by colour, a chrome agar, and we do have identification techniques now available with our latest software for moldy and platforms. So it's something that we can consider. I don't think we need to necessarily screen everybody like we were doing with MRSA, but certainly if there was an outbreak and if it was a ward specific problem, you know, from an HDU and ITU where you were seeing a yeast, a Candida type bug predominantly, it would be worth doing a screening of some time. So yes, if it's targeted, I think there would be a case for that. But that's just my opinion, of course. Where can we find more info about the chromogenic agar? Just let me move this aside because I did find this. So if you put Chrome agar Candida Plus into a Google search, it comes up with a website for Chrome agar, the company that make the agar. Just a little thing for them as well, but it does look quite good, and I'm sure other suppliers will be providing something similar. I'm sure BD and E&O will have something, but I'm not aware of that at the moment. Oh, and it looks like Adriana's put something in the chat with a link. Thanks for that, Adriana. And Erin's come up with E&O suppliers. So I think that's probably everything. I've covered everything. If anybody else has got any questions, please feel free to give me a shout. And if I don't know the answer, I'll obviously try and find out. There's just one other one coming. Silly question. In the old days, we used to put antibiotic disc on a plate to screen for MRSA. Is this something we could be done with Candida? I don't know. I can't. I don't know the answer to that. Disinfection procedures. It's your routine deep cleans on your wards. As far as I'm aware, I don't think there's anything different from anything else. We need to make sure we deep clean our wards. And when we moved away from having the ward-based cleaners and moved in with companies that provided cleaning services, in my humble opinion, that's when we started to get more infections and hospital nosocomial infections within hospitals, because they're working to a budget, whereas your ward cleaner wanted their ward to be the best ward in the hospital. So there was a good competition there to actually have the cleanest ward in the hospital. I missed a question from Reese. I'm not sure where that is. Can you let me know what it is, Adriana? Oh, it's all good now. Okay. All right. Well, thank you very much. And sorry for taking up your time, but I thought you'd probably want to listen to me rather than to listen to the budget. So with that point, I'll say thank you very much and goodbye.